Hello, Dr. Saguil. Could we check your audio and your video, please?
the heart, life's natural pump and the center of human passion and compassion. At Medela, we combine these aspects. Through global partnerships with leading researchers, we transform valuable knowledge into innovative clinical solutions. For over 50 years, we deliver high-quality Swiss medical vacuum solutions that now include adaptable surgical suction and convenient, easy-to-use portable suction systems for various applications in hospitals, clinics, or home care. Healthcare professionals value the reliability, user-friendliness, and quietness that come from Medela suction pumps. Continuing our success in developing cutting-edge solutions, we proudly present our next generation of suction pumps, Basic and Dominant Flex. The power of choice is at your fingertips. You can choose 40 liters per minute for whisper quiet operation, 50 liters per minute for most applications, or 60 liters per minute for turbo performance. Optimized hygienic design allows for simplicity when cleaning. Swiss quality and reliability integrated in a functional and modern design. You also have the choice of fully compatible fluid collection systems and accessories. Basic and Dominant Flex, the solution for all surgical suction needs. The pioneering chest drainage therapy system, Topaz Plus, digitally measures air, fluid, and pressure. And customized negative pressure wound therapy enhances performance, patient comfort, and controlling costs. Life is precious, and it needs passionate people to provide progressive care, working in partnership to save lives. Medela is all about true customer care. When you call, we answer. If you look for advice, we provide assistance. If you need support, we train and instruct you. Basic and Dominant Flex, offering you the power of choice at your fingertips. Hygienic, reliable, and user-friendly. All at a whisper. Contact us for more information.
Would just like to make a quick audio and video check, please.
Good afternoon.
Good afternoon, sir.
Hello everyone. Baliktad ba yung logo ko?
Hindi.
Pwede.
Na-correct na.
Hi, good
Hello,
afternoon.
everyone.
Gary,
Good afternoon, everyone.
Good afternoon, sir.
Welcome. Thank you. Hi, Kathy. Thank you for
Hi,
attending.
Doktora. Good afternoon.
Oo.
Thank you, Doktora.
Thank you din po.
Thank you for gracing our meeting.
Good afternoon, ma'am.
Maganda lahat ang tunog natin, ha?
Nadidinig.
may okay.
So, I think
Gary, okay ba yung audio ko?
Maganda. Malakas naman, Doktor.
Gwapo pa. Hindi lang maganda audio, gwapo pa video, di ba?
Salamat po.
Kagalang-galang.
Sobrang kagalang-galang.
Siyempre.
I think marami registrants natin, ano? So, the participants are coming in pa as we speak. But I think we can start on time naman, ano?
Yeah.
Okay, so everybody's audio is okay?
Yes, ma'am.
Okay, sige, thank you.
Yeah.
Thank you, Pawi.
Thank you.
Sure, ma'am. Thank you po.
Okay, bye.
Thank you.
Heavenly Father, we praise you for your blessings are abundant. Your hand is strong and your mercy is boundless. In these trying times, you have allowed us to become together as we seek to enhance the faculties you have given us. Bless our society and our speakers. Grant us the ability to share our expertise to our colleagues as we continue to be of service to your people. We pray for all those who are with us today. Keep us safe. Protect our colleagues and our families. Heal those afflicted by the virus and welcome to your kingdom our dearly departed. We pray that this occasion may empower us and offer new ways to continue providing healthcare to our fellow men in this time of need. May the success of this meeting and the knowledge we share today bear fruit of your greater glory. Amen.
Good afternoon. To formally welcome you to this webinar, here is Dr. Miguel Galvez.
Oh, I'm sorry. I thought I pressed it. Once again, good afternoon. Special guests, doctors, nurses, residents, interns, clerks, ladies and gentlemen. I would like to welcome you to a second of a series of webinars developed by the Philippine Surgical Infection Society in collaboration with the Philippine College of Surgeons and the Perioperative Registered Nurses Association of the Philippines. So with that, I would like to give up the floor and to hear a message from our president. So, welcome everybody.
Now for a message from the President of the Philippine College of Surgeons, Dr. Jose Antonio Saguil.
Good afternoon and welcome to the webinar of the Philippine Surgical Infection Society. As we have been working under the COVID cloud for the past 5 months, the need to innovate and devise new methods of ensuring safe surgeries in an environment lacking in essential resources is now the norm. Every little development and changes on how we can provide appropriate patient safety during surgery and management in critical areas of the hospital at this time is most welcome. Thus, such webinars as what we have today is good for all of us, and I am sure it will be informative, and its sharing to the surgical community around the country is something we encourage. The PSIS, an independent organization made up of healthcare workers with special interest in surgical infections, as well as infections that develop as a result of a procedure, will hopefully be part of the PSIS as an official affiliate society in due time. May I thus arouse among the surgeons, nurses, and others interested in this field to join us and be members of this relatively young organization. For your information, this group has already made its mark in the form of successfully having the government issue Presidential Proclamation number 971, dated June 23rd, 2020, declaring the second week of every July as the National Infection and Prevention Week, and the second Saturday of every July as Surgical Infection Prevention Awareness, or CPAP Day. And this was highlighted with a virtual inaugural commemoration last July 11. We are excited with the future of the PSIS, ably headed by Esther Saguil, who is also our speaker for this webinar. And so on behalf of the Board of Regents of the Philippine College of Surgeons, I wish the Philippine Surgical Infection Society the best and hope this webinar provides new and crucial information we all need in our surgical practice. We are firmly behind the PSIS in setting the standards in the OR and in the ICU. More power to the PSIS and, of course, to the Perioperative Registered Nurses Association of the Philippines, previously known as the ORNAP, or the Operating Room Nurses Association of the Philippines, who have been our close partners in the drama that unfolds within all the operating theaters in the country. Mabuhay kayong lahat, mabuhay tayong lahat, at salamat po.
To introduce today's speaker, we have Dr. Uykenko.
Hello. Yes, wait. Excuse me. Hi. Hello and good afternoon, everyone. My name is Dr. Uykenko, and I would like to present our speaker for today. She is the driving force in the Committee on Surgical Infection of the PSIS, and of course, our president in the Philippine Surgical Infection Society. She is a pediatric surgeon. She is a hospital administrator, and she is a very strong advocate of surgical infection prevention. Ladies and gentlemen, let us all welcome Dr. Esther Saguil.
Let us welcome our key speaker, Dr. Esther Saguil.
Good afternoon. Thank you for spending your Saturday afternoon with us. I'm here to talk about setting standards in the OR and ICU as a critical response to the COVID pandemic of 2020. Yesterday, the Philippine Daily Inquirer came out with a report of DOH that 6,735 medical frontliners have already gotten COVID, and of which 40 have already died. And these are grim statistics that we do not want repeated anymore. The objectives of this talk are to present the challenges brought on by this pandemic in the healthcare setting and discuss the adaptations in the healthcare setting necessary to ensure that infection prevention and control is practiced in surgery, and of course offer solutions to minimize infectious disease transmission in the OR and other critical care environments. We all know the chain of infection, and what is necessary to do is to break this chain in order to prevent disease transmission. You've probably seen this inverted pyramid before, and this is the hierarchy of hazard control. We keep on hearing on the news that vaccination is very important and we're all waiting for vaccination. But while waiting for vaccination, we should be doing something to at least mitigate the problem. PPEs are actually just at the lowest part of the pyramid because they're an individual response to hazard. Next to that is administrative controls. And in this talk, we'll be talking more about engineering controls, which is what we have adapted so that we can control the spread of disease. We've been told that the COVID-19 is transmitted primarily by droplet, but we do know that aerosols can be transmitted too. And at sizes of less than 5 micrometers, the droplet nuclei may be actually be inhaled towards your alveoli, leading to very severe infection. During the SARS epidemic, they were able to determine that during suctioning before intubation in 2 cohort studies, almost 60% will get COVID, the SARS infection. So knowing that SARS is actually the big sister of COVID, we are able to extrapolate some of the learnings in SARS to how we're managing COVID now. Regarding endotracheal suctioning, we have learned that about 20% of COVID sufferers will require hospitalization, and about 5 of them will need to go to the ICU for critical care support. And that is where ventilation and suctioning will be needed because most of them will have respiratory symptoms. So in these cases, a vacuum source and suction regulator are recommended for every treatment space, which means it's per patient to cover multiple patient management areas. We need to know that the airway is patent. It's kept patent because it is a life-saving procedure. That's why intubation, tracheostomy, they're done for these patients who develop respiratory symptoms. And for these patients, endotracheal suctioning must be available for all mechanically ventilated patients so that the secretions are removed in a timely manner. And in these cases, it's the mobile suction that prevents viral spread, not just from one patient to the other, but also from patient to healthcare worker. These suction pumps must have filters and accessories to help prevent the spread of viruses in care centers, and they're actually listed in the WHO booklet for SARS infection. When doing endotracheal suction, it should be done, if at all, should be done in a closed manner, closed suction system manner, and it should be performed very cautiously. So those with disposable collecting systems must be available in the critical care setting. When preparing patients for intubation, those with proven or probable COVID-19, there are several ways by which you can mitigate exposure and potential transmission of disease. One is by using full PPEs, and that is where wearing of PAPRs and full gowns may be done. Notice how sealed the mask is to the patient's face. Video laryngoscopy is now preferred over the conventional laryngoscope. In the UK, they pioneered these aerosol boxes, but in the Philippines, after trying it out for 1 to 2 months, we found it very bulky. So here, most people who intubate actually like using the plastic drapes, the clear plastic drapes more in the lower pressure to at least lessen the transmission of droplets or aerosols as they do the intubation. Of course, the number of staff has to be minimized, and all those who are not critical to this process, the intubation process, should leave the room. Regarding going back to surgery safely, we all know that all elective surgeries in virtually all areas affected by COVID had to stop. And we resorted to just doing the emergencies and the urgent cases. But now, starting June, we've already started doing elective surgeries, but it has to be a safe and comprehensive strategy because we cannot afford a second wave. And the strategies by which we can control this is by isolating COVID-19 treatment facilities, which we currently are already doing here in the Philippines, prioritizing surgical cases such that we first schedule patients who have long delayed surgeries and who have probably malignancies, cardiac problems, which really need urgent surgeries. We also, both the American College of Surgeons and the Philippine College of Surgeons have also taken to recommend screening surgical patients for COVID-19 using RT-PCRs, not antibody testing. And the fourth is maintaining a safe and clean and hospital environment, which we are about to talk about. So what is our critical response in the intraoperative environment? These are the 4 things that you have to consider. What is the condition of the OR ventilation? Do we have negative pressure in that OR? Number 2, how do we minimize the dispersion of aerosols, which we can do using suction with viral filters or even smoke evacuation? Number 3, how to do cleaning, disinfecting, and sterilization, and using environmental sanitation methods such as UVC irradiation. And number 4 is appropriate PPEs, which I have not included in this lecture. Let's say something about room pressurization. I'm sure everybody has been dying to know what negative pressure is all about. So what's the rationale for room pressurization? The American Society of Health Engineering has defined what room pressurization is all about. And it has something to do like this. A room has to be pressurized so that it's positive with respect to the other areas. And the reasons are, you have to protect the patients in the operating rooms and the clean rooms, and you have to protect sterile medical supplies and surgical supplies. So usually, the positively pressured rooms are usually the cleanest environments in a hospital. These are the examples of other positively pressured rooms during regular times. ORs, DRs, the NICU, pharmacy and lab, and the CSSDs. If you have a positive pressure room, then you also have a negative pressure room. So these are the examples of negative pressure rooms. These are the ERs, radiology waiting areas. I highlighted airborne infection isolated rooms or areas, the pathology area where the cytology is being done, nuclear med, autopsy rooms, and areas where there is soilage. For an airborne infection isolation room, it has to be negatively pressurized with respect to the other areas to prevent the contaminants inside that room from drifting to the other area. So it's keeping it in. But it just doesn't mean keeping it in the room, but rather there should be an exhaust, a controlled exhaust to take out this contaminated air without having to contaminate the rest of the areas. One very common use for airborne infection isolation rooms actually is when there is a patient with active tuberculosis, because since the bacteria is readily spread by air from one person to the other, we normally would request patient with active tuberculosis to be placed in a negative pressure room. Unfortunately, this has been an advice or recommendation has been poorly appreciated and followed. But now with COVID, suddenly everybody's talking about negative pressure room. So in pathology and histo labs, there's a substantial amount of chemicals, including formaldehyde and other airborne chemicals, which can cause unpleasant odors and some allergies in other people. So in these areas, negative pressure is also recommended. Now about operating room ventilation, there is a recommendation there should be at least 20 air exchanges per hour in the OR. Okay, so how do you do that? You have to reduce the amount of equipment in the OR. And remember, our ORs do not open windows to the external environment. So if you're going to have laminar flow, it may be distorted if you have additional equipment or personnel in the room. What we do is we install HEPA filters to remove aerosols and droplets. And we find that technically there's no need to convert all rooms to negative pressure rooms, but modalities such as in-room air filters or what we call air purifiers and antechambers may be considered. Minimizing the number of people in the OR at all times, particularly during aerosol generating procedures, is also very important to lessen the risks of exposure. We call it the high-grade exposure. The Philippine Society of Microbiology and Infectious Diseases came out with guidelines last May, and they recommended the use of HEPA filters. HEPA stands for high efficiency particulate air, which can also mean high efficiency particulate absorbing and arrestants. So they're typically made of fiberglass and they're able to filter out 99.95%. So that's very high already, no? But this is when the particles are more than 0.3 micrometers. It also allows efficient filtration, the rate at which the machine allows the air to pass through. So HEPA is actually for air filtration. It does not ventilate. You have to follow some parameters, and the manufacturers have recommendations regarding how big your filter has to be for a particular size of a room. So this is very important. You don't just buy a HEPA filter or an air purifier, but you don't know how effective that HEPA filter or air purifier is going to be with respect to the size of the room. There is now an available movable or portable negative pressure machine. So why do we say that this is a very good equipment? Having a negative pressure, it's expensive to set up a negative pressure machine. So if you have a movable or portable negative pressure machine, that will guarantee you can generate negative pressure in each room, and you can move it from one room to the other depending on where you're going to use it. So the currently available movable negative pressure machine actually has ULPA grade filters capable of filtering up to a 0.125 micrometer. So this is very small, it's much smaller. And these are very low noise, so they will not interfere with the OR environment. The nice thing about this is because they also have UV lamps, they need to have external remote control, so you don't get scared that you have to turn it on, enter the COVID room. You can actually turn it on remotely. So this can be used in a clean room facility, such as any ORs that are already existing or any ICUs that are already existing. So these machines have not just HEPA filters, but ULPA filters, which can filter up to 0.1 micrometer. So it gives you a lot of assurance when it comes to filtration of the air. These portable machines, like the BNC -1 SO400, is equipped not just with ULPA filters, but also with UV lamps, which additionally sterilize the room. So in terms of minimizing the dispersion, so you already have the HEPA filters or ULPA filters, but during the procedure itself, you also have to know the tricks on how to minimize dispersion. And one of the tricks that we do is to get the plastic kidney basin and put it around, okay, an instrument like a laparoscope or the trocar, so that whenever there's air being extruded or seeping out, it can stay within this kidney basin. It can be suctioned directly into the suction machine. During laparoscopy, what we recommend is to close the port taps before insertion and attach the CO2 filter to one of the ports for smoke evacuation. But then, as much as possible, you want to minimize the use of cauterization so you don't produce too much smoke. We advise not to open any of the taps of any ports unless they're attached to the filter or that being used to deliver the gas. Also to reduce introduction and removal of ports. So you want to be careful that you don't say that it's a wrong instrument, take it out, put it in again, because you want to lessen as much as possible seepage of air. Okay. We also recommend deflating the abdomen with the suction device before removing the specimen bag from the abdomen in case you do have a specimen, and to deflate the abdomen with a suction device or via port. So that is why from the start there were really a lot of questions about how to do laparoscopy properly or safely during the COVID pandemic. But after enough study, after enough trials and determination of how you can knowing a lot of how you can get the COVID virus, just by knowing this, you know that you can do laparoscopy safely now. There are just a lot of just some things that you have to know. So some words about surgical smoke inhalation. Even before COVID, if you look at the operating manuals of all your cautery machines, it says there that the surgical plume or the surgical smoke has to be evacuated or suctioned out because they are hazardous. They can be carcinogenic. And experts actually estimate the amount of surgical smoke produced daily in the OR is about 27. It equals 27 to 30 cigarettes. So you're actually a one-pack year smoker every time you burn 1 gram of tissue. So that's very important that you ask your assistant to suction it out. Now, because of concerns of coronavirus surviving in the surgical room, it's even the more importance now to suction that air or that smoke during the surgery. And what we have now is smoke evacuation systems, which is nothing more. It's a very simple device, but it's very helpful where the suction and the cautery are kept together in one device so that as soon as you burn tissue, there's smoke generated, it is automatically suctioned out into a closed suction system so you don't get to inhale. So the dictum is don't inhale. Just another setup, introducing smoke and aerosol spread in laparoscopic management, but all it means is keeping it all within this system. So it goes directly to the suction from the laparoscope down to the suction tubing and out. We do have suction machines now that are suitable for both ICU and OR needs. And in these patients, this can be battery operated so that if you don't have a socket, it can still work. And they have to have disposable virus filters and disposable fluid collection systems. In the UK, there is already medical guidance regarding vacuum. So most hospitals actually have portable, piped in vacuum or suction. There is some concern about piped-in vacuums because cross-contamination can actually occur. So there is guidance from the UK National Health Service that they do recommend portable suction units because these can be removed and sterilized before being used for another patient, and also for the safety of the healthcare worker. A medical virus filter is nothing more than a filter that is attached to this. This is it. That's the filter. And it's attached to the suction machine so that the virus retention inside that filter is very high at 99.99984. Okay? And it filters all types of coronavirus. So it makes everything safe. Your manong or your institutional worker, the janitor who cleans your suction machines is not exposed because the viruses are trapped in the filters. They're high performance and very dedicated, and it can make everybody much safer in the operating room and in the ICU. Also, the canisters, the ones that contain your wastes, your washings, the blood, they should have overflow protection. So they should not be freely flowing so that it just overflows and just, spreads everything. And this overflow protection on top, they have to have filters. so that the viruses can be trapped in these filters and not spread. They prevent the fluid from contaminating the central vacuum system if you do have a piped-in vacuum system or the other suction sources. With regards to surgical fluids, there are actually it's very important that the fluids don't spill, and I've seen it happen so many times. Liquids during suctioning can spill if the bag that suctions that where the fluid goes to is perforated, if the lid is perforated or torn, or it doesn't secure properly, or the manufacturer has used a thinner or inferior material, or the healthcare was had a slip up. And there are studies that show that nearly 38% of registered nurses experience splashes which are not acceptable, because this really expose our nurses, our staff, to potential for infection. And this is very scary when it comes to the COVID-19 infection. So what are must-have items in the OR? We would like to have the canisters in the suction, which have pre-filled solidifying agents. So this is nothing more like a gelling agent for your fluids. Once the fluid enters the suction machine in this bag, it becomes solid. So it reduces aerosol generation. It gives you peace of mind knowing that you won't get exposed to contaminated liquids. With regards to chest drainage, and I think you're all aware that the main problem of COVID patients is pneumonia, severe pneumonia. And in some of these ventilated patients, they do develop barotrauma, for which they will require chest tube drainage. Our conventional chest tube drainage have a positive pressure valve at the top of the device, and it allows exit of the virus into the environment, particularly when the patient coughs. And that is scary if the patient has COVID. So to combat that, there is a product like the Topaz that has an effective defense against harmful devices because it has an integrated filter on the top. Okay, so it has a filter, so it will retain the pathogen-sized particles. So it makes the environment of the ICU or the OR or the PACU much safer. Now, how about the post-operative environment? After surgery, the patient is wheeled out back to the ICU. The nurses and the staff inside the OR are still concerned about how that room and how the instruments and equipment are going to be cleaned, disinfected, and sterilized. As again, we already know that the main mode of transmission of SARS-CoV-2 is still respiratory droplets and contact, because SARS-CoV-2 can remain viable, proven 3 hours in the aerosol, 8 hours in copper, 24 hours on paper, 48 hours on stainless steel. I was surprised about that. And 72 hours in plastic. So because of this, aerosol and fomic transmission, although probably low, not likely, is still plausible. And in cleaning and in cleaning of instruments and environment, it's still the physical action of scrubbing with detergents and rinsing with water that removes the large numbers of germs, bacteria, viruses from surfaces. So this is the most useful method for removing viruses on commonly touched surfaces, or what we call high-touch surfaces. Thankfully, in the hierarchy of pathogen killed by disinfectants, enveloped viruses like coronavirus is actually the easiest to kill. So for the most part, everything should be routine when you clean and disinfect. And I think everybody knows it's done routinely. But what do we need to say? It's the key exceptions that you need to use an EPA registered product. EPA is Environmental Protection Agency. Why is this important? I don't know if some of you are aware that there was a policeman who died after being misted with a disinfectant which turned out to be undiluted, that can cause severe allergies and respiratory symptoms. So we ramp up cleaning and disinfection of environmental surfaces, especially those that are high touch, and allow time to air. Okay, so you don't go in while the floor is still wet, while all the surfaces is still wet. You have to allow time to air and dry before everybody enters for the terminal cleaning, and especially more so for the next case. So for environmental cleaning in the COVID OR, cleaning is crucial and it should be systematic and coordinated. Okay? We've seen and found that agents with antiviral activity, like just 70% alcohol, 0.1% sodium hypochlorite, or 0.5% hydrogen peroxide, are actually already effective as virucidal agents. And we also know that benzalkonium chloride and chlorhexidine are less effective. There are also hospital-grade disinfectants that are approved at FDA. But again, we have to emphasize that infection risk does not end with the operation. Everything has to be clean and disinfected until ready for reuse. And that includes even the BP sets, stethoscopes, and the like. Just some words about UV, because I know you've been hearing about it, everything has to go UV, surface disinfection. So how do this work? They generate, this UV lights generate, they destroy microbial nucleic acid, and there is a specific range, okay, of wavelength. That's the 240 to 280. That's the UVC range. There are now a lot of home grade UV sterilizers, like those for baby bottles or even handheld devices. No? But what we talk about is there are specific recommendations and guidelines when using UV light to sterilize operating rooms and critical care environments. The PSIS came out with these guidelines. Okay? The guidelines are actually telling you what you should know about UV lights. And one is it shadows. That means you have to have the least number of equipment inside a room that you want to expose to UV light, because otherwise, if there are many instruments and many equipment there, you're not going to obtain your target because there are going to be obstructions. The wavelength and the light intensity is important. It has to be optimal, and that's manufacturer dependent. If you have high humidity places, they increase the injurious effects of UV light. And thankfully, SARS-CoV-2 is one of those that's easily destroyed by UVC. For the record, UV light is not effective against bacterial spores. The exposure time is also very important. It is dependent on the intensity of the UV light. And the farther an equipment or a surface is from the UV light source, the intensity of the light decreases. So that means the sterilization will also be suboptimal. There is these are the various device considerations that you have to think about. So apart from efficacy, you want it to be portable because you can move it from one room or area to the other. It has to be durable because you don't want it to be non-functional after 1 month. Okay? It has to be easy to use and safe. And of course, everybody talks about how much is it. So the Moonbeam is one of those devices. It's I call it high tech because it has 3 arms and it moves vertically and horizontally, so it can cover all surfaces. It's also very portable, so it makes it easy. The use is much easier. We want to expose to UV light. If you are going to consider the use of UV light for cleaning and disinfection, you want to expose as much as possible the frequently touched or high touch surfaces. And what are these high touch surfaces? That's the bed rails, the IV pumps, all the things that everybody just keeps on touching, and you don't have your gloves. If you have your gloves, but you touch from one place to the other, you're actually the one spreading the virus. But there are also precautions when you use UVs. And it's our ophthalmology society that has issued the guidelines regarding this. It has been shown already in previous studies that UV-induced skin irritation and keratoconjunctivitis can occur. So we are told, yes, you can use the UV light, but you're not supposed to be in the room with a UV lamp. And if you have to be exposed, avoid looking straight into the light source. So what we tell everyone is you limit the access to the area when the UV light is on, put everything, make a huge X there. So this should never be used when a clinic or an OR is ongoing. With the standard recommendation, it's an adjunct to standard disinfection procedure. So what does adjunct mean? First, you clean, mop everything, wipe everything, and then you want to be very sure, then expose to UV light and make sure that the UV product specifications are compliant with the minimum recommendations, and that the protocol for using the equipment should follow the manufacturer's protocols, because we have to be very safe. You have to really make sure that you are safe. So how about instrument cleaning, disinfection, and sterilization? So yeah, we're done with the room, but we now have to think about how we do the instrument cleaning and how we clean the rest of the environment. For non-critical equipment which need cleaning and low-level disinfection, okay, regular detergent and household bleach are often not enough to remove blood and organic debris. And this is why sometimes you see your clamps having some more blood that seems it has already gone through the autoclave, but there's still organic debris there. And that's not good because biofilm, that's biofilm, it does contain significant bioburden and can pose risk for infection. So after cleaning, or we call it the babad, okay, we have to soak. Soaking in anionic and neutral detergents, they should be soaked in an appropriate disinfecting solution such as Precept. Precept is more effective than hypochlorites because it's sustained release. 50% stays initially as free as available chlorine, but 50% combined will become available later on as it stays soaked. So there's a prolonged bactericidal and virucidal effect, and therefore better infection control because there's make sure that the virus is killed. So for these solutions or wiping solutions, you don't do double dip. Double dip is you've already immersed something in it and then you take that out and then you immerse something else. That's not acceptable. For semi-critical instruments such as endoscopes and laryngoscopes, these enter non-sterile body cavities. They need higher levels of disinfection. I'm sure those in my age group and a little older, they know about glutaraldehyde. Because for the longest time, if you drop an instrument, still need it for that surgery, you ask somebody to soak it now in 30 minutes so I can use it again. But we've shown that glutaraldehyde, okay, although it is safe, but it has risks for irritation and potential toxicity. So now there's an upgrade. That's the taldehydes. So we call it the Sidex OPA. The nice thing about the Sidex OPA is, unlike the regular Sidex where you just babad for 30 minutes and then just take it out. With Sidex OPA, it has chemical indicators, so you can determine the efficacy of the solution after use. So you can use these solutions, okay, in the ORs, in the GI departments, particularly for the endoscopes, in any part of the offices or healthcare settings where you need some higher level of disinfection without necessarily having to do sterilization. And for critical instruments such as laparotomy sets, we need sterilization that is reliable. Okay? You can sterilize using steam, that's the autoclave. You can use hydrogen. You can use plasma. And we found out that we needed to sterilize N95 masks because of the shortage. The steroid system was very effective because it's one of the plasma sterilizers. So these sterilizers have biological indicators, so you're assured that your instruments are properly sterilized. Okay. So all these things that we've talked about are additional necessary standards that you have to start putting in place in your ICUs and your ORs if you want to make sure that not only the patient is kept safe, but also the healthcare workers. Because I think everybody now knows that it is the the number of healthcare workers and manpower that is now creating the shortage. They're now the shortage, the manpower. In the past, they said it was ventilator shortage. They said it was the ICU bed shortage. But now the DOH has already acknowledged that far more important than ventilators, far more important than the the ventilators and the beds, it's actually the presence of the healthcare workers. Because once your healthcare worker gets sick, that's a minimum of 2 weeks of quarantine. And if they do contract COVID-19, okay, God forbid that they have severe or critical disease, everything gets disrupted. The scheduling gets disrupted. So it's very important that at our level, we think about our safety at all times. So I think that's it. And for any questions, you can address your questions here via email at the email address fieldsearchinfectionsoc.2018@gmail.com. Thank you very much for listening.
Now we'll have an open forum moderated by Dr. Uycuenco.
Hello. Hello. All right. Oh.
Okay.
Hi, good afternoon. All right. So, okay. So, before we before we go to the open forum, no, I would like to ask our reactors to prepare their statements, their reactions. Now, so can we go first to Dr. Catherine Colaiko, the Vice President of FIX?
Good afternoon, Doctor. Good afternoon to everyone. I'd like to thank you, the PSIS, for the invitation to join you this afternoon. I want to thank Dr. Saguil and commend the very comprehensive coverage that she did in the time given. And I'm glad that there was a lot of focus on the engineering aspects of infection control. Dr. is right. Much of the discussion has always been, even up to now, on personal protective equipment. No? And understandably, it's because there's really a lot of fear still and anxiety amongst the healthcare workers, especially every time there's a wave of new healthcare workers falling. We are already falling short in hospital staff. Wherever, I'm sure in all hospitals. And so it is always a concern. But PPEs are limited and many of them cannot really be reused. And so there has to be an additional or a group of means to prevent infection. You know? And the ideal really in any area of the hospital, but more especially in the areas that are supposed to be sterile, the IC, the OR, no, and areas that are critical, such as the ICU, it's very important really to practice all aspects of infection control. Doctor presented the inverted pyramid, no, and all of these are cannot be individually done and be effective. You know, all of it has to come together. You may have very good engineering controls, but no protective equipment, or the other way around, or you might have no policies at all in your hospital. And so every individual is just scrambling for themselves. No? One duty time, they might be cleaning a particular way, and another time, a particular way. So all of these policies have to come together. But it's very important, in fact, to identify the need for environmental decontamination. So, there's been a lot said already previously about how to screen patients prior to surgery. There's been a lot of debate on that and a lot of questioning of the expenses that go into this. But really, there's really a need to protect not only our patients and not only the surgeons, but the whole team. You know? So I'd like to mention about the discussion on the decontamination. No? These are actually standards really for hospital grade decontamination. No? As far as instruments go, they haven't really changed outside from the time of pre-COVID to COVID. You know, and I'm glad Doctora mentioned that also the coronavirus is actually very vulnerable, no, very vulnerable to these disinfectants. But we cannot also be lax in implementing these. No, Dr. mentioned, okay, the patient has already been brought back to the room. No, what else do we do? So of course, all of these cleansing and all the cleaning and decontamination is necessary. And not only that, but of course, we have to re-emphasize that those who are responsible to do all of these cleaning have to protect themselves as well. No? So they should also be provided with the proper PPEs, such as the N95, no? Especially when you're cleaning, and all splash protections, especially because these are highly infective pathogens. There was a mention on the HEPA filters, and I think one of the issues with many hospitals still up to now, and we get questions about that, is these are all good to know, but they're also very expensive. No? So what do you do in the absence of these? And this is where you will have to discuss it with your engineering teams as far as air exchanges go. And that is also where you have to be more meticulous with your environmental cleaning, with your decontamination after the procedure, the terminal cleaning that goes into that, what solutions to use. No, Dr. mentioned glutaraldehyde. Ay, naabutan ko yun. No, I was in that batch, and yes, it is still effective, but there are toxicities associated with it, and so there have been amendments to that, and the Sidex OPA is one of that. As far as I wanted to just also touch on the surgical smoke, no, and I'm glad Dr. also mentioned that, because in the past we'd also get a lot of questions on that. The surgical smoke, can surgical smoke aerosolize the coronavirus? We really don't know. No? Until now, there really is still no, or there really aren't very strong evidences for it, but there aren't strong evidences that they don't. So at this point, I think any the hazards of surgical smoke in its ability or capability of causing infection should be looked into. And if there is that potential, then that also has to be addressed. And Dr. is right. No, there was previously, when this all started back in March, there's a lot of apprehension about how do we conduct these surgeries? Can we do this? Can we do endoscopies, laparoscopies? Can we do all of this? No, there was a lot of fear about handling these cases, and I think the data up to now is still evolving. But it's been 5 months, 6 months already since the time of the lockdown, and there have been surgeries already that have been performed, and maximal protections are concerned. I think it is a reality really to really just invest also per institution on infection control measures. No, it might not be the HEPA filter, it might not be the portable negative pressure machine, which would be so ideal really for many hospitals that do not have negative pressure rooms. But the very basic still of infection control will still matter, you know, and those are the proper air exchanges recommended by the WHO and the CDC, and this has to be worked out with hospital engineers as well. Yes. So thank you, Dr. Saguil. That was a really very, very comprehensive and very interesting lecture. Thank you. Dr. George?
Hello, yeah, all right. I was muted kanina. So let's hear from the Perioperative Registered Nurses Association of the Philippines, their president, Mr. Gabriel Naig, for their reaction on today's lecture. Thank you, Dr. Colaiko.
Good afternoon, everyone. Good afternoon, everyone. Sir, naririnig po? Sir?
Good afternoon, Gab.
Good afternoon. Naririnig na po?
Hello? Yeah, we just don't see you.
Yes, opo. Mayroong challenge po yung video ko, opo. Pasensya na po.
Yes, Sir Gab, go ahead.
Okay. So, good afternoon, everyone. On behalf of ORNAP, I would like to extend our greatest great appreciation to PCS, Dr. Salud, and PCS President, Dr. Saguil, for always involving our organization and these endeavors as a continuing education program, likewise to the company partner, CentroMed, for making this into a success. Dr. Saguil's presentation is an excellent and practical guide in the performance of our role as perioperative practitioners. Her discussion likewise serves as a basis in formulating the guidelines and procedures. Thus, standards are set for infection control for that specific matter. As perioperative practitioners, we must be knowledgeable in resource management utilization We cannot demand what we need due to some limitations and challenges we are now facing. It is our role to look for a solution and find ways to meet our needs. This can be achieved by trust, good leadership, collaboration, and positive attitude. Above all, this endeavor should not compromise patients and healthcare workers' safety. In addition, being an advocate for the patient and healthcare worker safety is crucial in delivering quality care. To be an advocate, we must learn to speak up if non-conformance and errors are observed, while observing the proper process that needs to be employed. As part of the team, it is increasingly important to be equipped with knowledge and skills to render quality care in embracing the technological advancement and evidence-based practice that can help ensuring a safe workplace, like katulad nga na-discuss ni Doktora kanina, like environmental cleaning, processing of instruments, smoke evacuator machine, etc. So we have the knowledge to prevent infection. What we lack is the will. So thank you very much.
Thank you, Gab.
Thank you.
Thank you, Gab. Thank you, Sir Gab. And now we will be going to the Q&A portion of this. We have still a few minutes. So anyone in the panel, even our reactors can answer, no? Of course, Dr. Saguil, no? So there's a question here and I'm just going to group it all, no? So somebody is asking between the difference between air exchanges per hour or CADR, clean air delivery rate for HEPA filters. No, I think, does anybody know? It sounds like a more an engineering question kasi.
I'm sure Dr. Olacolaico will be able to answer that better.
Yeah.
As far as air exchanges are concerned, there are standard air exchanges that are based on room dimensions. No? So the depth of the room, the height of the room, if you have a door, what size is the door, the size of the window, the angle of the window to the room. There are quite a number of factors, I think, that are considered. And yes, it is an engineering question, which unfortunately I am not an engineer, but it is a question that we pose and that we do pose to our engineering staff when we are in the process of renovations or creating new rooms, especially when we want to create isolation rooms. No? In the early days of managing COVID cases outside of the OR, we're talking about the general hospital areas. There has been a lot of emphasis on these. No? If you don't have negative pressure rooms, what can you use? Because negative pressure rooms are expensive. They are an investment, quite a number, and you can't just, if you do a negative pressure room, you'll find that 1, 2, or 3 are not even enough. So what are the options for that? And so DOH put out its guidelines that said, well, you can just have single rooms in these cases, but you want to ensure the proper air exchange, the Mach 12. So at that point, the ones who will be able to truly identify the dimensions for these would be your engineers. And there have even been guidelines on what would help to improve that air exchange. Would it help with the exhaust, opening your windows, opening their windows and your doors? No? But of course, we know that we cannot open the doors for our patients when they are in fact in isolation. So the other option is the window, and that is an option provided that the window doesn't open to a highly populated area where there's a lot of foot traffic. So those recommendations have to come in. But as far as the air exchanges are concerned, that is an engineering concern. Now, the other one, the CADR, that's a spec of the machine. No? These are the process by which the air moves. Doctora mentioned that the HEPA filters, the air, it has to go slow through that machine to be filtered out, to be cleansed. To be the whole point of the filter, the HEPA filter, is to bind those pathogens. So the movement there is going to be a slower movement. Again, these are specs that should be in the manufacturer's manuals and should be reviewed before purchasing, I presume, a HEPA filter for your facility.
Yes, thank you, Dr. Colaiko. And I suppose we all, with your answer, we've already answered some of the questions asking about, um, installing a exhaust fan instead of the true negative pressure room, or opening up the windows. No, there will be limitations, and we advise everyone to talk to their hospital engineers. No? So there's one question here in how in requiring patients to undergo RT-PCR before elective
Procedure.
surgery. Somebody's asking how long can you have that RT-PCR result to be considered valid?
Yeah, that's always going to be a tricky question, no?
It's going to be
Because it's always going to be a tricky question because you get one test today and then you get infected tomorrow. So it's really it's very tricky. But the recommendation really is that if you will do an RT-PCR, and it's still a recommendation for elective procedures, especially if the individuals come from high endemic areas or the prevalence of COVID is high,
Shots.
or the exposure in the immediate environment is high. But validity ideally is a week. No? It's unfortunate that in many testing centers, the turnaround time is still a
It's one
long
week.
time. Yeah, 1 week, yes, 4 days, 5 days. Earlier on in March, April, we get it in 2 weeks, which is really impossible. But now there are a lot of testing, accredited testing centers that have been able to deliver a turnaround time of 48 hours. And so though it's a more feasible approach now, but the idea really is not more than a week from the time of the procedure, no, for from the time of the elective procedure.
Thank you, Doctora. And there was another question with regards to the respirators that most of the healthcare workers use nowadays.
Mhm.
No, so unlike before, we just only knew about the N95s. Now everybody's using full face elastomeric
Half face.
respirators, half face, just elastomeric. So does anybody in the panel want to answer this? How should it be cleaned? Do you have any special guidelines on how it should be cleaned?
It's actually the manufacturer that will give you the appropriate guidelines on how to clean the respirators. For example, with the N95 masks, if you ask the manufacturer of the N95 mask, they'll tell you that they don't want it being recycled or being being reprocessed. But it was because of the shortage that we decided that CDC, even the US CDC decided that, well, rather than not have any respirators, probably can recycle, but only for with certain exclusions and with certain criteria. Same is true with respirators. I know somebody who bought one, a full face respirator, and used alcohol on the lens, and voila, it is now opaque and you cannot use it anymore. So it's very important that the manufacturer's indications, or should be followed. The
Especially
general rule
with
is
the
sodium hypochlorite. A very dilute sodium hypochlorite solution is an ideal, and then you dry it properly. And of course, you change filters because
filters,
especially for
yes.
those half face and full face respirators,
Mhm.
you cannot use it forever with the same filter.
Yeah.
Okay, so you also follow the manufacturer's recommendations regarding changing of filters. Oh,
Uh,
there are other hospitals now that have PAPRs, the purifiers, the powered air
Yeah.
purifiers. And I saw one hospital that said that they can just borrow from one person to the other. You can use from one person to the other. And I don't think it's very hygienic.
Mhm.
I think if you're going to share
Yeah.
PAPRs, you can share the motor, but you don't share the headpiece.
The headpiece, yeah.
Buy your
Yeah.
own headpiece.
Yeah. Yeah.
That was rather funny.
uh, uh, lalo na kung nagkakakain na ng garlic nung nauna sa'yo, no?
Yeah, shawarma yan.
Shawarma. Anyway, going back to our topic. This is one question that I'm particularly fond of. In using UV light, will the people in the other room be affected with UV light?
Other room?
A separate room?
In the separate room?
If it's an enclosed room, then there should be no reason that the UV light will affect the next room. No? Remember, the reach also of the UV light is not very far. That's why Dr. Saguil mentioned that the farther the objects that you want to clean or disinfect is from the light source, then you might not really reach the sterilizing point for that one. So I don't think you can affect the next room as long as the openings
door
are
is
closed.
closed.
Yes, the door is closed.
Thank you. And
there are many kinds of UV lights now, huh?
Yes.
Aside from the UV lamps that you use to sterilize, you can even put UV inside your split type air conditioning to clean your room. So there are many applications now of UV light. So it's very important that you check with the manufacturer or the distributor regarding the specifications. And also, if you're going to use UV lamps, you have to know also the dimensions of the room.
Yes.
So because if you're going to use a very small UV lamp, but you have a very large ICU, that's not going to be effective either. So that's very important to know.
Thank you. And just to add on that, we have to remember that UV is actually light. So the closer anything you want to sterilize, the better.
Yeah.
Kung malayo ka na sa kanya, hindi mo na sisinagan yon, wala na siyang effect. And UVC lamps, despite being very effective, are also not great in long distances. So kung nasa kabilang kwarto ka, you're safe.
Hindi siya tumatagos, hindi siya X-ray vision.
No. Hindi siya, Somebody's asking about dry misting. I think those are one of those many ads you see on social media. They sell those fogger machines, misting machines. So does anybody think that they are a good idea in hospital disinfection, particularly in the OR or ICU?
Dr.
Dr.
Yeah, as far as the different, there are actually a lot of misting machines. One that has been in the market even prior to COVID was really the hydrogen peroxide types, and they have been effective in depending on the area that is being misted, but some infection control units would use it for even sterilizing or disinfecting air vents in a particular setting, but it depends really, I guess, on what kind of misting machine that you would be using, because there really are some that were created for disinfecting a particular room. But there are a lot that have been coming out now, with COVID, and those misting tents that a lot have been putting up. There really hasn't been any evidence of its effect, and as a matter of fact, of course, we know that the DOH has advised against
it.
misting the healthcare worker, because precisely what happened to that individual who had an allergic anaphylactic reaction to all of these misting procedures. But to be fair, there are in fact machines that it's been for a few years already that they've been around for disinfecting rooms, disinfecting rooms with hydrogen peroxide.
Yes. In addition, from the lecture, remember the sequence of environmental sanitation. It's always clean, disinfect, sterilize. So to mist without wiping, without cleaning, mechanical cleaning, that would be an incomplete cleaning and disinfection. So misting is a disinfecting process, but the cleaning, the mechanical cleaning should never be forgotten.
I think misting falls also, or would probably be an adjunct as well.
Yeah, adjunct,
just like the
just like UV.
Yes.
Yeah.
Thank you. And how about this one, Dr. Saguil, I think is very apt question for you. Are there separate protocols for pediatric patients who will undergo surgery,
No.
particularly neonates with surgical problems? We know that thankfully, they're not really strongly affected by COVID-19. But do they all need a PCR swab prior to surgery? These pediatric patients?
So just some observations for the last 6 months. We've been lucky. Our pediatric patients were much less affected in comparison to our adults. In PGH, we get to admit about 10 per week, of which 9 would have very serious comorbids like leukemias, okay, and major GI anomalies. But there are COVID positive neonates. And we just discussed one, a diaphragmatic hernia patient who tested positive for COVID at day 3 of life, even if the mother was negative. Okay, we were able to get the swab. So we were thinking, was the mother pre-symptomatic or did you get it in the delivery room? And that baby developed cytokine storm. So my only point in saying that, in mentioning this, is you cannot totally discount the possibility of a neonate or a pediatric patient developing COVID infection. So far, right now, I have 3 COVID positive appendectomies. Okay, and these were all asymptomatic. Their post-operative courses are so far okay. So it does seem to follow the observation, even in the US and in Europe, that children seem to have less respiratory symptoms in comparison to adults. But same, we still test, even children we test. And the problem with the children is we test the child and we have to test the mother or the caregiver. And now there's evidence that there's transplacental transmission of the coronavirus. And there's also some evidence that there may be viral particles in the breast milk, but so far they're not infective. So the current recommendations now is it's still safe to give breast milk to babies, even if the mother is COVID positive, as long as the proper precautions are taken.
Yeah, thank you. Um,
You got muted.
Yeah, you're there. A lot of the questions are coming in with regards to PAPR and personal, the doctors carrying their own personal respirators, elastomeric respirators. So, should the hospital regulate what the doctors bring in? There's a hospital infection control side there. No, if you bring your own respirator, you bring that respirator from hospital A to hospital B. Maybe hospital B doesn't want you to do that. No, so what are your thoughts on this?
uh, from the infection control standpoint, it's really very hard to tell doctors don't bring it because they don't listen to you. No? They'll always tell you, what if I get sick? Who's going to answer for that? No? So even the overalls, hazmats, you tell them there's no need for that, they'll still wear it. So I think the just more prudent approach there is you can't really ban them from using it. But if they are in fact going to bring it from hospital to hospital, then they really have to disinfect that, after using an exposure to their patients, especially because the reason it's not just for your protection, but whatever you wear, you to potentially infect. And I think that just has to be reiterated to all healthcare individuals. So it's not just doctors who wear them now, even nurses, midwives, they're walking around, manongs, nursing aides,
Yeah.
they're all wearing it. So yeah, it's very hard to deregulate that from. Yeah.
I believe many of the employees or staff were given these half-face respirators more for their for the peace of mind rather than
Peace
for
of
the
mind.
actual need. Okay,
Yes.
and I really saw that they felt very taken care of when they were given these half-face respirators. But as I keep saying, all these infectious protocols have been in existence before COVID.
Yes.
And if you're going to say that if ever there is something that good that came out, or if it heightened the awareness of everyone regarding infection prevention and control, TB has always been there. Pneumonia has always been there. These are airborne diseases. but we never took the correct precautions because they felt, but because COVID kills and it kills fast, it disables many of us, it spreads so fast, then our we know that we all cannot let our guard down now because the consequences are so dire.
And I'd like to mention, because you have quite a number of participants, so I just think about it now, no? Dr. mentioned that it has been around for a very long time, putting patients in negative pressure rooms, especially TB, no? Cavitary TB, MDR TB, and the reality is even the healthcare workers really were not very careful about that.
Yeah.
And so lately we've been having, the PhilCat, and I just want to reiterate that the TB is still the number one killer, no, still.
Yes.
So yeah, it's very good that this has really heightened our awareness for infection control. One of our board members in the Philippine Hospital Infection Control Society was saying one of the good things that came out about from this is that in the past, only infection control practitioners actually knew what PPEs were, know what was a
Yeah.
PPE. Now even the merchants in the palenques know what PPEs are. No, so there's really a heightened awareness that we need to, in fact, practice good hygiene and the very basics of infection prevention and control. Yeah.
Wow, I think that was a very apt statement to cut short our very engaging discussion. Na medyo napapahaba na tayo. I just looked at the program and I saw, oops, we're several minutes overtime already. So we'll probably be revisiting these situations again. There were a lot of questions about ultraviolet sea light now, so maybe that's a different topic later on.
And maybe Jobert, maybe we can still answer those questions and provide the answers in the YouTube. We'll give the answers in the YouTube channel so that they won't be okay.
Yes, we will provide the answers. Yeah, we can parse through all the questions. We can maybe we can be answering them one at a time, no?
Yes.
Para mas magandang discussion, no? So with that, if you'll permit me, we can now proceed to the message from our sponsors. They will be presenting an AVP and to be followed by the closing remarks from Dr. Renato Montenegro, the Regent in charge of the Philippine College of Surgeons Committee on Surgical Infection.
The heart, life's natural pump and the center of human passion and compassion. At Medela, we combine these aspects. Through global partnerships with leading researchers, we transform valuable knowledge into innovative clinical solutions. For over 50 years, we deliver high-quality Swiss medical vacuum solutions that now include adaptable surgical suction and convenient, easy-to-use portable suction systems for various applications in hospitals, clinics, or home care. Healthcare professionals value the reliability, user-friendliness, and quietness that come from Medela suction pumps. Continuing our success in developing cutting-edge solutions, we proudly present our next generation of suction pumps, Basic and Dominant Flex. The power of choice is at your fingertips. You can choose 40 liters per minute for whisper quiet operation, 50 liters per minute for most applications, or 60 liters per minute for turbo performance. Optimized hygienic design allows for simplicity when cleaning. Swiss quality and reliability integrated in a functional and modern design. You also have the choice of fully compatible fluid collection systems and accessories. Basic and Dominant Flex, the solution for all surgical suction needs. The pioneering chest drainage therapy system, Topaz Plus, digitally measures air, fluid, and pressure. And customized negative pressure wound therapy enhances performance, patient comfort, and controlling costs. Life is precious, and it needs passionate people to provide progressive care, working in partnership to save lives. Medela is all about true customer care. When you call, we answer. If you look for advice, we provide assistance. If you need support, we train and instruct you. Basic and Dominant Flex, offering you the power of choice at your fingertips. Hygienic, reliable, and user-friendly. All at a whisper. Contact us for more information.
We'd like to now welcome Dr. Montenegro for the closing remarks.
Hi, good afternoon again. Esther, before I close the session, I'd like to just ask you a simple question about your lecture. I, for one, want to actually review it. Are we going to upload this? Or is this going to be shown on YouTube?
Yes, sir. This will be available on the official PSIS channel.
Okay, there it is. Ladies and gentlemen, let me first thank Dr. Esther again. I actually enjoyed your lecture, Esther, and your fan base is definitely increasing. And surely we will invite you again. I also enjoyed, the comments of Dr. Catherine.
Yeah.
And of course, Gab. Gab, your message was rather philosophical. So to end the session, again, to everyone, we appreciate that you stayed online with us for the last 1 hour. It was a very fruitful 1 hour. Again, congratulations, Esther. And thank you again for graciously accepting the challenge to remind us, educate us, and reassure us that we are, in fact, doing our best in this crisis. This webinar is more than just a commitment of the Philippine Surgical Infection Society, the Perioperative Nurses Association of the Philippines, or the ORNA, and the PSIS, of course. This also reflects our advocacy towards surgical infection prevention and awareness. What we emphasize this afternoon is that for us to win the battle against COVID, we need to be educated. We need to be aware, and continuing medical education, such as this web-based seminar, is actually the way to go. And to repeat what the PCS president just said earlier, last month during the last July, during the second Saturday, we celebrated the first ever Surgical Infection Prevention Awareness Day, which culminated the 1-week celebration of the National Infection Prevention and Control Week, which always falls on the second week of July. This is, of course, to drum up support for the Philippine Surgical Infection Society. And so, ladies and gentlemen, to finally end the session, I would like to invite everyone in behalf of the Board of Directors of the Infection Society to be a member of our group. Everyone with a stake on surgical infection, nurses, surgeons, infectious disease specialists, operating room nurses, you are all welcome. Again, congratulations and a pleasant afternoon to all.
Thank you.
And a happy birthday, Boogie.
Happy birthday!
It's a good way to, celebrate my birthday.
Happy birthday. Happy birthday. Thank you everyone for listening. And we'll make every effort to answer all your questions.
Yeah, I was afraid, Chito, you'd say that. I was expecting that, Chito.
Nakahabol
Late
ako.
ka kami. Thank
I
you,
made sure.
sir.
Ay,
Thank you to all our participants.
thank you.
Thank you for joining us this afternoon. All those who registered will receive an email with a link for the certificate of attendance and CPD credits.